Well, how you doing, Michael?
Excellent, thanks. Thanks for having me. I really appreciate it.
Thanks for coming and kicking things off.
Excited to be here between between two revenue cycle ferns. I think is what it looks like here in your setup. I like
Where's
that.
Zach when you need him,
Exactly.
right?
I don't know. I didn't see him here. Is he speaking? No. So,
That would be epic.
it would be really good.
Well, a day two, like I have the froggy voice from like staying out with clients too late. So.
Yeah, it's happened to me in the altitude. I can't drink enough water to get rid of it.
I know you have a big cup of water there.
Yes. It's one gulp per cup. Exactly.
So I'm trying to think. We got to hang out last fall at a conference and geek out about the revenue cycle.
Yeah.
And talk about 1,000 things in the column of. So what's going on in your shop in the context of RCM innovation?
Yeah, I'm really excited to talk about it. Thanks for asking. So on the trying to change the paradigm and how revenue cycle is managed from a cost perspective. We're trying to take the burden off of the docs and off of the coders by really going to be disruptive. That's where the most cost is. Docs are our most expensive and scarce resource, and coders are similarly some of our most scarce for sure and expensive resources, and they're the ones that do all the work. No offense to my other colleagues in the rev cycle, but I firmly believe that coding is the most important part of the revenue cycle because what goes on the claim matters, whether it's fee for service or risk. Those CPT codes, those diagnosis codes drive everything.
Yeah.
And docs are great documenters. They're not always great diagnosis pickers.
Yep.
And so we've developed a truly AI and machine learning technology that removes both of them from the process. And it's been extremely successful, and it's got a lot of great benefits, and it's very different from anything on the market. So we're really trying to disrupt, change, reduce cost for sure.
Yeah. And are you doing that for are you focused like a lot of folks doing lower level, office visits? Or are you trying to tackle even the more complex cases?
We're starting in the radiology space, and that product is commercially available.
Okay.
And we're automating at Mass General Hospital in Boston about 82% of all radiology cases without coders touching it before the claim is dropped. So we actually incorporate all edits into our predictions as well. So we're not automating and then sending it to a scrubber system that a coder has to touch before it becomes a claim. We're actually incorporating all those edits. So to get to over 80% at an academic medical center like that is really, really impressive. So that's one thing that we're really, really focused on.
And are you doing like supervised learning where they're training, the engine, like, hey, this is correlating or this is a false positive?
Yeah, there's a tremendous amount of QA and machine learning and deep learning and artificial intelligence that goes into the secret sauce.
Yep.
And it's been very successful. After radiology, our next product to go live is pathology that goes live in July, as does gastroenterology within the Mass General Brigham network. We've got a number of clients that have all signed up for radiology, and then once we're live, they're starting to sign up for our other ologies, as we call them.
Yeah, exactly.
After this, we're moving to the surgical space, then ED, and then we want to get into the HCC world as well.
Okay.
So that's the path is essentially want to look into prior authorizations and potentially as well auto adjudication by leveraging machine learning to confirm with the payers that they believe in our models, they understand them, they can ping them to make sure that they're still working as expected, and then maybe auto adjudicate claims instead of having to do this very rigorous, time-consuming process. I mean, our AR days at MGB are about 31 days for $7 billion in professional charges, which is pretty good. But I got paid tomorrow for the work I did last week, yet the doctors have to wait 31 days. The industry doesn't make any sense. So we're going to find ways to remove that burden, that cost, and find ways to do other things with the money.
That's fantastic. I'm curious too, like when you first went through that change, could you describe, because innovation's tough, right?
Mm-hmm.
First you have to pick what are we going to innovate? There's the change management aspect. It's getting people comfortable with that.
Yep.
Can you talk a little bit about that? Like, what was it like for the staff?
They were actually really excited because we were in an environment with multiple interfaces, multiple systems, and so anything we could do to make the process better was great.
Yep.
And because this was a tool that was developed within the rev cycle shop, we knew what all the pain points are. And so instead of getting something off the shelf that someone built in their garage that then we tried to overlay into our system that didn't understand workflows, we were able to find a way to make it seamless, to make it very effective, and to eliminate a lot of the pain points that we had from an operational or financial perspective. Yeah. For instance, the tool Codametrix doesn't charge you for things it doesn't automate. Other tools on the market do for everything to run through their system, but then they only automate 40, 50, 60%.
Yeah.
But that's like paying your local neighborhood person to cut your lawn, and at the end of it, when he's done,
Yeah.
he says, "Yeah, you can do the back if you
Yeah,
don't mind,
right.
but you have to pay him the full amount."
Yeah.
So that's something that we built into the pricing to say we're only going to charge you for things that we actually automate.
Yeah.
So
There's a novel concept. Right?
there's a novel concept. Yes, exactly. So and incorporating edits is actually really unique as well. A lot of the other players in the space, when they automate something, it still goes to a scrubber, and 10, 15, even up to 20% of what is automated ends up being touched by a coder. So you lose that percentage of automation, whereas ours is 80% of MGH is not being touched by a coder until it potentially gets denied.
Yeah.
And we're seeing about a 60% lower coding related denial rate for things the machine touches versus what people touch.
Wow.
So that's an enormous benefit for us from a cost perspective. You're getting a reduction in lag. Your cash is coming in much more quickly, and you stop that ping pong between the teams on the back end, which is just so painful.
Yep. Yep. So what do you do when you have, because like you said earlier, sometimes there are some docs that they've done the same amount of work as another doc, but they have not given as much detail.
Yep.
So does this help in any way, like for change physician behavior?
In the short term, it might not, because when you extract the features from those two different notes, one might be more rich with data and the other might not. But what we've been able to do is to turn a number of our teammates or code into educators and auditors, as opposed to looking at this as a way to reduce our expenses. So we wanted to find a way to accommodate growth. We've had a 12 or 13% compound annual growth rate in cash for the last 10 years. So we have been able to leverage technology to just keep up.
Yeah.
And so we could let those coders to reach out to our physicians to help them to improve their documentation.
Yeah.
So,
well, we have clients that, to your point earlier about how important just take something as simple as CPT coding.
mm-hmm.
We have clients where we're actually also computing the payments, incentive payments to the doc. So we're part of the engine that does that.
Mm-hmm.
So it's like critical,
mm-hmm.
to your point. Is there potential for that where you're actually doing paper performance?
We haven't explored that yet, but there's a number of things on the roadmap that we're starting to think about as to what else we can do once we get into the space.
Yep.
The biggest challenge that we've had, on the one hand, the docs are jumping for joy that they don't have to worry about charge capture. We like to say in the company that no doctor went to medical school to be involved in charge capture. Right? Yeah. I'm still waiting to meet that first one.
Right.
And if you know one, let me know. I'd like to meet him or her, because I haven't yet in the entire time I've been in the healthcare industry, not one.
Yep.
So on the one hand, they're really happy that we took it away from them. So most of the surgeons at MGH no longer do charge capture. Our legacy product within the four walls of MGH is doing that for them. So they don't have to worry about CPT code changes, diagnosis changes, preference lists, all that we do for them. On the other hand, they're a little bit concerned about their revenue because it's tied to RVUs, and comp plans are tied to CPT
Absolutely.
codes. So we have, as we brought them on board, we do a 1 or 2 month review of what the machine did versus what they would have done, or have them review the cases, and then they sign off, and then they move forward to being on that. And then they've been very happy. We've not had a doctor go onto the tool and eventually come off yet. And hoping we won't have that happen at all, ever.
Yeah, it totally makes sense. What about this? What's your advice for folks that are, because I know a lot of folks that are starting to lean into mid-cycle and let's automate coding.
Mm-hmm.
What's your advice for them on lessons learned, and how long does it take, and do you emphasize change management more than another area? Or?
Absolutely. We've found if we've rolled this number of these types of tools out in multiple ologies across multiple hospitals in our system, as well as with Codametrics clients, is that it's not the technologies that is hard, the connections, HL7, that's easy. It's the workflow and the trust. And so you definitely have to build that no matter what you're doing, right? You're changing your payment posting process. You're using another
data trust is the key word. Yeah,
absolutely. That's been very successful. And building trust with the teams is really helpful. Yeah. We give mobile phones. Call me if you have a question.
Yep.
And we very rarely have people that call with a complaint. So we've been trying to be very customer service friendly. Our billing shop in Boston is really focused on our practices, our patients, and our providers, and making sure that we do everything we can every day to make their lives easier.
Yep.
We take as many of the revenue cycle tasks off their plate as possible so that they can focus on what they're really good at, which is clinical operations.
Yeah.
You don't want me doing a surgery on someone's knee,
Exactly.
and I don't want them doing revenue cycle.
Exactly.
So we try to find that good balance where we can.
It's the classic letting people work to their license. Right?
Absolutely.
Taking friction out.
Yep.
How do people think about the impact that can be made? So take a shop that's got 100 people in the coding process.
Yep.
What does it look like a year later?
It depends on the individual shop, what they want to do. We've seen about a 30% ROI
Yep.
For our clients, and we guarantee that in year one.
Yep.
And you can obviously redeploy your staff. Our first couple
Sure.
of clients have taken there, they've reduced the coding staff that are associated with radiology, and they move those coders to other areas to reduce backlogs. They've not used it as a way to reduce cost. Over time, as we roll out more ologies
Yep.
and they get more efficient, then they could, through attrition, reduce their overhead and their FTE count. But right now, I think everybody's just so strapped for keeping up. And
keeping up is I think what we're seeing in the work that we do around automation, like in the back office and stuff, is that it's people aren't worried about like, hey, there's folks losing their jobs. There's plenty of work to be done.
Absolutely.
We need this because we can't find the labor. Yep. There's so much labor.
Yes, exactly.
Shortage, and it's different in different markets, but it's still an overall problem, right?
Yep. So I'm involved with Codametrics as a co-founder and in a number of functions with there. But in my rev cycle hat at Mass General and Brigham, we've also done a lot with RPA, and we've built about a dozen bots that have taken about 15 FTEs out of the rev cycle process on a monthly basis, on a recurring monthly basis. But we're struggling to find ideas to what to automate, because no one's going to raise their hand and say, "Oh, job could be is bottable, like eliminate," right? No one wants to do that. So finding those opportunities is hard, but also building trust with the team that you may be doing X, but we have plenty of Y, Z, A, B, C that is waiting for you to go do. So don't think that you're pigeonholed into this one job. So we're trying to find those ways that the bot can do something that, is a highly repetitive, very easy to be trained on, very clear with a workflow, and isn't overly high risk.
I would also say that just like the number, there's so many folks, we talked about it a lot yesterday, accounts are not getting touched. You have sometimes 20, 30% of accounts that get over 90 and they don't have the labor. So many times it's just the bots to take away the clerical part so that follow-up folks can be doing the more important
they can
tasks.
alert you to things that need to get done as opposed to doing work. Hey, this account's aged. Maybe we should have, you can do something. Our EHR is also really good at providing those alerts as well. So it's how you configure it and leverage the technology that you have. It's not always about adding the new bell and whistle. It's trying to make sure you're taking advantage of the ones that you have now. About half of the bot ideas that we've had when we go out to do to identify the process, because you can't build a bot on a non-documented crummy process, we find out that the processes needs to be tightened up, or our EHR can actually do that work now that we did about 5 years ago. And so half bot ideas turn out to be process improvement opportunities within Epic, because we can take advantage of better process in Epic, or we built a legacy process into Epic, which we shouldn't have done, or Epic now has that functionality and we've been able to do that. So that's been a real benefit for us as well. So it's a combination process improvement as well as a bot opportunity.
One of my favorite questions to ask folks is like, if we have whatever 250 to 275 billion dollars of waste in the revenue cycle alone, what kind of impact do you think that we can make, like say in a 5-year period?
I think
in attacking waste.
If people really wanted to be forward thinking and were willing to take a risk and believe in this, I think we can eliminate half of the waste within the next 5 to 7 years.
I like that. Yesterday, the consensus was 30%. But I mean, technologically, you said it earlier, it's not the technology. The technology could do a lot more. It starts at the boardroom and the C-suite and down, right?
You mentioned trust is something that's really important. It's not only trust with us rolling out the technology and how it's going to impact revenue or workflow for the practices. We also have to build trust with our payer colleagues, right? Their member and our patient is the same person, but we have a different view of that individual, right? We use two different words to describe them. So who's really responsible for that patient's care? And the hospital physician might argue me, and the insurance company might argue me. And they both come at it from a different perspective. Typically, the very stereotypical two sides of the same coin. And if we can get on the same page with them, we can reduce an enormous amount of waste. So we've worked with some of our local payers and say 98% of what you deny, we ultimately pay on appeal. So why are you continuing to deny it? Let's do an audit annually and work that and eliminate this waste. We've not always been successful, but people are just, there's not a lot of trust. And so when there's not a lot of trust, it's really hard to be creative and progressive. And you
described a use case that we're so passionate about right now. We have a thing called Payer Action Center, and it's about putting the and letting the provider and the payer really, hey, and you said it perfectly. A lot of times those claims are going to get settled 18 months from now at a certain payment to charge ratio.
Yep.
Why don't we just settle them now and avoid all the touches?
Correct.
Right?
Yep.
Let's have a little real-time auction.
Right.
And just settle them now, and then we'll write you scripts that upload to your system. You know,
Yep.
There's so much
There's
opportunity.
a tremendous amount of opportunity, and
Yeah.
I think it'll be a very quick transition. What we've at the cloud, right? At the keynote speaker this week, on Sunday afternoon, he talked about how we're in the age of oh my gosh, I forgot the word now, so I feel bad that I brought it up.
Yeah.
But the last 5 to 7
Well,
years has changed completely, right?
Yeah.
The way we do business, the way commerce works, the way we communicate, right?
Yeah.
The way we drive with Waze, the way we communicate with Zoom,
Yeah.
Instagram, everything, the way we work with order food,
Yep.
Google, the cloud. It's going to accelerate. More and more people are going to understand this. They're going to be creative and take things that we're doing to the next level. We're going to
Yep.
continue to be creative. And if you're not on this train, you're going to be left behind, and you're
Yeah.
going to become just a dinosaur, and you're going to end up with significant problems.
It's a really, really good point. They're making us wrap up here, but I feel like I need to have one of those things in my ear. We're like, okay.
Is there a hook? What if we just kept talking?
Yeah, we could try that. Let's see what happens. They'll
See what
drag us
happens.
off-
Exactly.
drag us
This
off
is fun.
the-
I don't want to go.
Drag us off the set.
Yeah. The lights
Um,
will start blinking.
Oh God, no! I just forgot what I was going to say. Well, let me ask you this: like, is there anything else in the column of RCM innovation that you want to mention or you're passionate about, other than coding?
We're trying to do the best thing we can for our doctors, and
Yeah.
I think we have to find ways to make that the focus. If we can support them in their mission to support patients
Yeah.
and do it at the lowest cost possible, that allows them to have as much money as possible
Yeah.
to invest in the next generation of doctors,
Yeah.
teaching, community outreach, and obviously clinical patients. So
Yeah.
there's a lot of opportunities. I think we just have to rethink how the entire care paradigm is delivered
Yeah.
and designed.
Yeah.
Probably design it before you deliver it, of course. So whether
Sure.
that's telehealth or that is through improved revenue cycle processes, meaning taking advantage of technology and being more efficient, there's just a lot of opportunity. This is a behemoth of an industry. It's 20% of GDP.
Yeah.
It's typically behind every other industry with regard to how it takes advantage of technology
Yeah.
and advances. And I think if we can catch up, there's a tremendous amount of opportunity to make a big difference.
Yeah, I couldn't agree more. I think that it's, using the ways. What I'm passionate about is like, hey, the dollars are there, right?
Yep.
So it's just value engineering that money into value,
Yep.
right?
Yep.
So I think that, we have to stop. I mean, we're both veterans in this business, and how long have people been saying that healthcare is a decade behind, right?
Yep.
That's just my whole career. We're
Yep.
a decade behind.
I've been a decade behind for 25 years.
How about we start changing that?
Yeah. Well,
You
there's
know,
a significant
leapfrog.
amount of just entrenched players that are difficult to move.
Yep.
And that's part of why Codametrics is really excited to be a disruptor,
Yep.
because I think we can make a small dent in some of that, and then maybe that will lead to other changes as well. So
Yep.
we can make incremental changes. It's not going to change overnight, but we don't want to be here a decade from now saying, I wish we could have done something differently. So we believe that we can do that now. We've got the evidence that we can, and we're making a big difference.
Well, hey, Michael, I really appreciate
Thanks
it.
for having me. Really
The future is
appreciate it,
bright, right?
Absolutely.